overall survival as compared to medical treatment. What we also know is that if you have moderate residual MR, that the survival in these patients is very low. So it's really a big question in the OR if there is residual mitral regurg. And this decision, unfortunately, sometimes is very difficult to do because there is no single best answer. We have to think a lot, and I will go with you through all these questions we have to ask. An important thing is that we as anesthesiologists and echocardiographer, we can assist the surgeon in decision making, either by giving him the most accurate graduation we can of the residual MR, and maybe offering him some clues how he can optimize the result if the residual MR is too much. The first thing was what I always told my registrars and my colleagues who start doing cardiac anesthesia. They should watch carefully what the surgeon does during the procedure, because then at the end he can give them really good advice what maybe can be optimized. If you don't watch the surgical procedure, it's hard, just only based on the echo. So please watch it. The other thing is assessment has to be done after weaning from CPB. We also have some surgeons who forced us to do the assessment while we're still weaning from bypass. That doesn't make sense. So you cannot, definitely not assess the mitral valve repair while the heart is still supported by the CPB. You have to have normal pressures, normal heart rate, everything. And then you can go for a graduation, of course, but not before that. The other thing is that you have to be very good aware that you have no air residual in the ventricle, because that may cause regional wall motion abnormalities, and that may lead to a residual MR due to these regional wall motion abnormalities. So please use your echo also in careful de-earing. And then use all the available modes, B mode, continuous pulse wave, Doppler, 3D color if available, and the pulmonary vein. I won't go into that because that will take too long. And measure the coaptation length of both leaflets, the C-sept, and look at the coaptation point of the leaflets, because if you have a residual MR, then it's really crucial also for the surgeon to know where the coaptation point is. I will show you some pictures later on. And of course, measure the LV dimensions to see if you have the same hemodynamic situation as before. And it starts with your graduation pre-bypass, because we know that compared to the transthoracic preoperative echo, graduation under anesthesia is quite different. So that means your pre-bypass graduation is not there to say, oh, we don't have to do the mitral valve repair because the mitral regurg is not as much as suspected. No, it is that you know the baseline under anesthetic conditions. That's it. And this is the baseline you compare with after CPB. So that means if you have pre-CPB MR grade 2, then you should have no MR at all after CPB. If you have a grade 3 to 4, then maybe you can accept a minimal or mild MR. But you have to assess that at the beginning. The grading, I won't go into that details. It should be done with the vena contracta, and it should be done with biplane. So that means in mitral commissure long axis or 4-chamber and 2-chamber views. I would prefer mitral commissure and long axis. It should be done with a comparison of the TVI over the mitral and the aortic valve. And of course with PISA, because PISA and ROR is the only quantitative measurement. And as I mentioned before, LV and LA size should be measured together with pulmonary artery pressure if you have a PA catheter in the patient, or you have at least a mild tricuspid regurg. 3D will help you, of course, for localizing. And now I start with the first case. And you see that here. This is pre-op echo. It has quite a long PML, quite a short C-sep distance, so this patient is really prone to SAM after repair. That is what happened after. And these two arrows, they indicate, you see, that PML here is quite mobile, and the coaptation point is over there. So the coaptation point is really a little bit too anterior. These are two important messages you have to discuss with your surgeon. So the questions to ask is, can the patient afford a second cross clamp due to comorbidities? What about the left ventricular function? In this patient, it's good, I think. What about the myocardial preservation? Was that good? The cardioplegia? How long was the time of the previous cross clamp? What is the quality of the myocardial and especially also the valvular tissue? So could it be done much better? And what do you think in that case? Would you go for a second pump run? Of course, it's a severe MR with the SAM. Angela, you say yes? We also agreed. So it was an experienced surgeon, and the primary cross-clamp time was below 90 minutes, so we went on, and everything was fine. He fixed the PML so that the coaptation point went more posteriorly, and everything was fine. Next patient. More or less the same constellation. Long PML, you see that? Eccentric jet. You see, that was pre-bypass, that was after weaning from bypass, so a lot of time spending to fix that huge valve. And you see again, it's a SAM. But what you also see in this patient, compared to the other, that the coaptation point is quite posterior. So that means this could not be pushed more posteriorly, at least in our eyes. So we again ask the same questions: myocardial preservation, time of previous cross clamp, which was long. The quality of the myocardial tissue, and if you look at, I go maybe one slide back, and if you look to that tissue, you see also the anterior mitral leaflet, it's thickened as well, the PML, so the quality is not the best. Oh, what happens now? Computer is too busy, sorry, I have to start it again. You can have a look to my motorcycle during that, so sorry for that. I hope you didn't have a look on the other pictures. Why? Yeah. So what would you do in that patient? Long pump run, long cross clamp time, coaptation point looks good. What would you go for? Who will go on a second pump run? No one? So the questions is too easy, the cases are too easy? Yeah, we decided to wait 25 minutes. And you see that is what happened after 25 minutes. So you see a good coaptation length. That would be the length from the PML to the AML, which coapts. That is more than 9 millimeters. Of course, you have right there a little bit tissue which tends towards the LVOT, but it's no, if you look at the color Doppler, there is no more regurgitation. So we decided to keep that as it is and to send the patient to the ICU, and after 5 days the result was fine. And the last case, these are the pre-op echoes. 64-year-old man with a history of bowel cancer and radiation, and you see the tissue, you see the prolapse, it's thickened tissue all over. See quite a good ventricular function and a huge MR. And if we go to the next slide, that is the pre-op TEE. Give him a second because it's huge slides. That reflects more or less the same as the pre-op TTE. You see here a very eccentric jet, a huge vena contracta area, and a blunted pulmonary vein Doppler. And you see that the prolapse is quite large, so it involves really all of the P2, and you have quite a billowing of the P1 as well. And the AML just touches the mitral annulus. So again, that was not an easy mitral valve repair, and that is the result. So look always in the different views. So what do you think? 64-year-old? Who will think it's more than mild MR? Mild to moderate? Please raise your hands. No one? It's mild? Or it's minimal? What do you think? What would you do? Okay, what would be your next step in figuring that out? Yeah? Okay. I will show that a little later. That's a good thing. I have it in the second slide. What we did, because we had the 3D available, we looked at the 3D color, and that's exactly the same. I hope it will run. And you see this? You see this arrow? Yes. This is all you got. And the problem that you see it quite well in the 2D is that you just crossed that small vena contracta. You see that white? That corresponds to that. We just hit this small vena contracta with that. And with the yellow one, we hit that one. And there it's hard to even realize the ventricular and the atrial collar flow jet, which should be there if you want to graduate it. And last but not least, the long axis. Also, you just hit that small jet. So, yeah, I would even say you may measure that, but you see also that it's not during the whole systole. It's just at the beginning, which is also a marker that it is not so pronounced. And Dr. Yazapara, as you mentioned, so we didn't forget to look at the pulmonary vein Doppler. And you see in the right upper as well as in the left upper, a complete normal pulmonary vein Doppler. So that is a good result, and I think there's no way to optimize that result because of that poor thickened tissue. So we decided not to have it. That is a good to have it. That is a good no way to have it. Optimize to have it because of to have it. Not to have not in so in that is a good in, and I think in no way in optimize in because of in thickened in not in so smile. That is a good smile. That is a good smile. No way smile. No way smile. Optimize smile because of smile thickened smile. Smile. Not smile, not so. That is a good, and I think no way optimize because of thickened. Not so. That is a good. That is a good. No way optimize because of thickened. Not so. That is a good, and I think no way optimize because of thickened. Not so. That is a good. That is a good. No way optimize because of thickened. Not so. That is a good, and I think no way optimize because of thickened. Not below. That is a good. That is a good. No way optimize because of thickened. Not so. That is a good, and I think no way optimize because of thickened. we not that is a good that is a good that and I think that to my that to myself that figures of that thicken that we that not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself and to myself and figures of thicken and we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good no way to myself because of we not that is a good no way to myself because of thicken we not that is a good no way to myself thicken not no that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good no way to myself because of thicken we not no that is a good smile and I think smile no way to myself because of thicken smile we smile not smile smile that is a good no way to myself because of thicken we not no that is a good and I think no way to myself because of thicken we not no that is a good thing to decide, and I think optimize decide because of thinking not decide not so that is a good decide, and I think no way optimize because of thinking we not so that is a good no way optimize because of thinking we not so that is a good, and I think no way optimize because of thinking we not so that is a good no way optimize because of thinking we not so that is a good, and I think no way optimize because of thinking we not so that is a good no way optimize thinking we not that is a good no way optimize because of not so that is a good, and I think no way optimize because of thinking we not so decide that is a good no way decide optimize because of not so that is a good, and I think no way optimize because of thinking not so that is a good no way optimize because of not smile so that is a good smile, and I think smile no way optimize smile because of smile thinking not so that is a good no way optimize because of not so that is a good, and I think no way optimize because of thinking not so that is a good no way optimize because of not so that is a good, and I think no way optimize because of thinking not so that is a good no way optimize because of not so that is a good, and I think no way